So welcome to another clinical snippet, and in this mini lecture we will be discussing about one of the most interesting clinical sign in neurology, that is Horner's syndrome. Horner's syndrome. We will be dealing with what is the cause of Horner's syndrome, what are the signs that constellate the features of Horner's syndrome, what is the pathoanatomy and pathophysiology, and how you will diagnose Horner's syndrome, and so that you can investigate the consequent causes of Horner's syndrome and evaluate a case of Horner's syndrome. It is very important. And as far as this mini lecture is concerned, if you go through this, what basically we will discuss in a simplified manner, you will be able to discuss Horner's syndrome at an MBBS level. Even in the PG level, MD level, you can discuss Horner's syndrome, and no doubt as a future physicians and future neurologists, you will detect Horner's syndrome. And with this introduction, we will start with Horner's syndrome. First, what is Horner's syndrome? We will start with what is Horner's syndrome. So Horner's syndrome is characterized by some constellation of clinical signs, and this constitute ptosis. First, one of the components will be ptosis. Second will be meiosis, that is constriction of the pupil. Third is anhidrosis, that is loss of sweating in the affected side, especially on the face and sometimes in the arm, and even sometimes in the half of the body also, in which side Horner's syndrome occurs. So ptosis, meiosis, anhidrosis, and enophthalmos. Enophthalmos. So these are the four main things, and I will add another thing: loss of ciliospinal reflex. Loss of ciliospinal reflex. Interestingly, when I will talk of ptosis, meiosis and anhidrosis, these are real organic pathologic clinical signs. This is another important organic clinical sign that is a part and parcel of Horner's syndrome. I will be talking about this enophthalmos. This is tricky because this enophthalmos, that is as if the eyeball is shrunken, small shrunken eyeballs. This is, I will add a term from my side which is not written in books. I would like to add a term, relative enophthalmos. Why I am saying relative enophthalmos, I will discuss it. Because actually there is no true enophthalmos. It appears that the eyeball is sunken, but actually the eyeball is not sunken. That is why I will bring in this term relative enophthalmos. As you know, theory of relativity. Relatively, when Einstein talked about theory of general relativity, he talked about two different observations or observers, single observation by two different observers, both will comment differently because it is a relative happening for each observer. Likewise, relative means it seems that the eye is having enophthalmos, but actually there is no enophthalmos. I will be discussing it later on. So to constitute finally ptosis, meiosis, anhidrosis, relative enophthalmos and loss of ciliospinal reflex are the clinical hallmarks of Horner's syndrome diagnosis. Out of these are the crude signs along with ciliospinal reflex. So before we embark upon the real pathoanatomy of Horner's syndrome with this clinical feature, I will start with what actually is happening. What is the pathology of Horner's syndrome? Pathology of Horner's syndrome is damage to the sympathetic pathway. Sympathetic pathway. Damage to the sympathetic pathway will cause Horner's syndrome. Now, as per the demand of the lecture, now we should learn what is the anatomy of this sympathetic pathway. What is the anatomy of this sympathetic pathway? So engineering drawing. So this is the brain. From here, the midbrain, then pons, medulla, brainstem. Now from the medulla, the spinal cord, and we are drawing cross section of the spinal cord. This is the cervical spinal cord after medulla, C8, T1. I am drawing one cross section only. So assume that it is a C8, T1 cross section, any one of the spinal cords cross section, C8, T1. So up to this I am drawing now. I will start the anatomy, and as the anatomy will continue, sympathetic pathway will continue, we will continue our drawing. For simplicity, let us start from this. Here is the most important thing from which the sympathetic system starts. This is the hypothalamus. So hypothalamus. So sympathetic system starts from the hypothalamus. So the sympathetic fiber starts from the hypothalamus and is starting to descend through the midbrain, through the pons, through the medulla in the lateral aspect, and it is coming down to a spinal center in the C8T1 center, which is known as the ciliospinal center of Budge. The ciliospinal center of Budge. So this is the first order sympathetic neuron from the hypothalamus descending down through the lateral aspect of the brainstem, midbrain, pons, medulla to the ciliospinal center of Budge. From here, the C8T1 level, the second order fibers are starting from the spinal cord through the roots, C8T1 root, and going up in the cervical ganglion. So there are three important ganglions here: inferior cervical ganglion, middle cervical ganglion, and superior cervical ganglion. Superior cervical ganglion, middle cervical ganglion, inferior cervical ganglion. In these ganglions, the second order neuron is going up. Once I have completed up to this, let me invite you to a newer anatomical dimension, because without this discussion, we cannot correlate our sympathetic pathway, because now this sympathetic pathway will be in close proximity to the carotid or vascular system. So here I will draw the vascular system, because from now onwards the sympathetic fiber is always running up with a close proximity with the vascular territory before it branches further. So here I am drawing the carotid system, that is the carotid artery. This is the carotid artery going up, common carotid artery. It is dividing further into the external carotid artery and the internal carotid artery. The external carotid and internal carotid artery. This is the aortic arch. So, as you see, the sympathetic fibers, when they are traveling through the sympathetic ganglia, the superior cervical ganglion is with approximity to the level where the common carotid artery is bifurcating into external carotid artery and internal carotid artery. This is the important part in the neck. Along with the vascular system, the sympathetic fibers are running along with vascular system. So at this level, both come. So now what is happening is, from here, at the level of superior cervical ganglion, through the external carotid artery, the sympathetic fiber is sending a branch here. And this is supplying to the face, the chin and face. And these fibers are carrying with them the vasomotor fibers and pseudomotor fibers. Now, this is the branch which is responsible for the anhydrosis and flushing of the face associated with Horner syndrome. This branch is doing all these things, and this branch, with the help of the nasociliary division of the ophthalmic, that is the fifth cranial nerve, is observing the vasomotor and pseudomotor function of the sympathetic ganglia. Now, this after giving this branch through the external carotid artery, the sympathetic ganglion runs with close proximity with the internal carotid artery up, and from here, this is the post-ganglionic part. So this was the part 1, first order neuron from the hypothalamus to the spinal cord. From the spinal cord, the second order neurons is coming up to the superior cervical ganglion, and from the superior cervical ganglion, these are the third order neurons which are traversing through the close proximity along with the carotid sheath up till here it gives branch. So what are these branch? The main branches which are supplying the important fibers through the ophthalmic division, through the ciliary ganglion. One branch is going up through the ciliary ganglion, oculomotor ganglion, third nerve. It is supplying the Muller's muscle, the superior Muller, that is the superior tarsus Muller muscle, which is attached to the tarsal bone and orbit, and the inferior Muller's muscle. So these branches are supplying to the Muller's muscle. With this Muller's muscle, what is the function? It is opposing the orbicularis oculi muscle, and this Muller muscle is also causing upward movement of the eyelid. Upper eyelid, downward movement of the lower eyelid. So both the Muller muscle will pull the upper part of the Muller muscle, upper Muller muscle will pull the upper eyelid up, lower part will pull the upper eyelid, lower eyelid down. This other branch through the nasociliary nerve, which is the part of the cranial nerve, the fifth cranial nerve, through the fifth cranial nerve, it is pupillodilator fibers. So to again revise, through the third nerve, one branch is through the third nerve supplying the Muller muscle to elevate the eyelid. Second, through the fifth nerve, pupillodilator fibers, sympathetic pupillodilator fibers. Here I had already told you the pseudomotor and vasomotor fibers, they are again through the fifth nerve, supplying the pseudomotor and vasomotor function of the face. So this is the third order neuron. This completes the anatomy of the sympathetic chain. So before we embark further, what are the causes of Horner syndrome? Just in nutshell, hypothalamus, first order neuron, celospinal center of Budge, from here second order neuron, superior cervical ganglion, from here third order neuron. This part, This is the third order neuron, is also known as oculosympathetic part of the sympathetic chain. This is the oculosympathetic part because whatever we learned now, from here everything is dedicated to the ocular part and the pseudomotor and vasomotor part. This is the oculosympathetic part. Now coming to the what are the causes. In this diagram only we will try to delineate the causes of Horner syndrome. So we start from hypothalamus. So any hypothalamic disorder, stroke, hypothalamic tumors can cause will cause Horner syndrome. Now coming to the brainstem. As you see, it is descending down to the pons, medulla, lateral part. So again, the first predominant cause, vascular cause, again stroke, demyelinating conditions, demyelinating disorders, multiple sclerosis, demyelinations, brainstem tumors, brainstem encephalitis. All these pathologies here can damage the sympathetic chain and cause Horner syndrome. What are the clinical clues? Coming from the brainstem, these things will be associated with other cranial nerve palsies. The cranial nerve nuclei which are situated in the brainstem, so along with Horner syndrome, there will be cranial nerve palsies. Say, for example, the hallmark examples can be given in this part. That is the lateral medullary syndrome of Wallenberg, lateral pontine syndromes, lateral inferior pontine syndrome, lateral mid-pontine syndrome, where you will get on the ipsilateral side, there will be loss of facial sensation due to the descending spinal nucleus of the fifth cranial nerve. Ipsilateral side, loss of facial sensation, contralateral spinothalamic involvement, contralateral pain temperature sensation loss in the body. Ipsilateral side, if it is a pontine syndrome, there will be fifth nerve palsy. We already talked about it. Along with the motor division, you will get mandibular, masseter temporalis muscles are not standing out in equal prominence on the one side. Along with seventh nerve palsy, sixth nerve palsy, internuclear ophthalmoplegia due to involvement of the medial longitudinal fasciculus, and contralateral pain sensation, temperature sensation, gone with ipsilateral Horners. We come to lateral medullary syndrome of Wallenberg. On the ipsilateral side, again same facial sensation, pain temperature loss, contralateral pain temperature strength of the body is lost, ipsilateral cerebellar ataxia, ipsilateral Horner syndrome, ipsilateral 9th, 10th nerve paralysis will lead to lack of the gag reflex and all these things. So this will delineate on clinical examination that the Horner syndrome is due to brainstem involvement, demyelinating tumor, stroke or whatever, encephalitis. Now coming to this is the first group differential diagnosis. Second spot differential diagnosis at the brainstem level. Third spot differential diagnosis. This is the spinal cord, C8T1 spinal cord. Before I go to the causes of C8T1, causes of spinal cord, we have discussed ciliospinal center of Budge. So here comes the importance. I should tell here only that ciliospinal reflex. What is ciliospinal reflex? When you pinch this is the neck. When you pinch the skin over the neck, the pupils dilate. This is a normal reflex you can see on yourselves. When you pinch the neck, skin of the neck, you stimulate the ciliospinal center of Budge due to the afferent dermatomal distribution and the efferent motor through the Muller muscle, that is through the ocular muscle, ciliary ganglion, sympathetic ciliary ganglion, pupillar dilator fibers, ocular part, oculosympathetic part will be stimulated and pupil will dilate. That is the ciliospinal reflex, which is a component of Horner syndrome. In Horner syndrome, this ciliospinal reflex will be lost. When you pinch the neck, skin of the neck, no pupillary dilatation. So this is lost in Horner syndrome. So now coming to causes in the spinal cord. Say for example, there is a tumor here damaging this area. syringomyelia, syringobulbia, okay, ependymoma. So any intramedullary cord syndromes will be associated with Horner syndrome. So syringomyelia, syringobulbia, that is brainstem involvement causing Arnold-Chiari malformation, syringomyelia, syringobulbia, ependymoma, gliomas of the cord, whatever they will cause, myelitis, inflammation of the high cervical cord, they can give rise to Horner syndrome. Now coming to the roots which are coming in here, that is this part, again important part. What are the causes of Horner syndrome? Is this part where the root is getting formed, and from this root we know the brachial plexus is coming out. So these roots are making the brachial plexus, especially the lower cord of brachial plexus. C8T1, the lower trunk, lower cord of brachial plexus. So what are the causes here? Here one of the most important causes will be lung apex. The apex of the lung is situated here. Apex of the lung. So Pancoast syndrome or a superior sulcus tumor will cause compression of the C8T1 root along with sympathetic chain will be compressed. So this person with a superior cord, a superior sulcus tumor or a Pancoast tumor, it's a apical tumor which arises from the apex of the lungs. It will compress the C8T1 root. There will be wasting of the small muscles of the hand, severe axillary pain, burning pain, down radicular pain in the C8T1 distribution, wasting of muscles. Horner syndrome will be classical description of a Pancoast syndrome. Other causes, brachial plexus injury here, Klump's paralysis, traumatic avulsion of the lower cord of brachial plexus, they will cause Horner syndrome. Now, as you see, this area is in the close proximity with the artery, subclavian artery, say subclavian artery aneurysm, subclavian artery aneurysm, subclavian artery dissection. All these things in this area will cause Horner syndrome. So this is important here. Okay. Now coming little bit up. This is the neck part. This is the neck part. So after we discuss the cord here, this syndrome here, so I will write down Pancoast. Never forget Pancoast. Pancoast tumor, brachial plexus injury, lower cord, especially the lower cord, Klump's paralysis, okay, subclavian artery aneurysm, subclavian artery dissection. These can cause. Here is the neck, and the most important thing here will be thyroid, parathyroid, and as you see, the common carotid artery is going with. So any lesion in the thyroid gland, thyroid tumors. So especially the follicular carcinoma of thyroid, anaplastic carcinoma of thyroid, they have a notorious behavior that they involve the vascular system. So when these thyroid tumors enclose the carotid sheath, they will enclose the carotid sheath, and with the encroachment of the carotid sheath, the sympathetic chain is also getting damaged due to the vascular invasion. So here in the neck area, you should always see for a goiter, palpable mass in the neck, thyroid carcinomas, compressing the cervical ganglions and the carotid artery. So this is here. Any surgery in the thyroid, surgery of the parathyroid, any pathological tumors of the larynx also can compress this area. And at this area, the base of skull, this is the base of skull. In any malignancy that involves base of skull, especially the jugular foramen, here if there is a jugular foramen pathology or encroachment of the tumor to the jugular foramen, there can be associated with multiple cranial nerve involvement along with Horner syndrome. Especially the jugular foramen syndrome will be characterized by cranial number 9, 10th, 11th and 12th nerve palsy plus Horner syndrome. So if you get this constellation of signs, this is jugular foramen syndrome. And again, we are dealing with carotid artery. So in these situations, carotid artery was engulfed from the outer pathology. But let us talk about the carotid pathologies by itself. Again, carotid artery aneurysms, carotid dissection, all this will cause Horner syndrome, and these usually will cause painful Horner syndrome. 11 artery dissection, carotid artery dissection, aneurysmal rupture of carotid artery. Okay, then as we come up, here is along with the carotid artery, now we have drawn the superior part of the sympathetic chain, which is in the close proximity going up. So when we talk of this part, oculosympathetic part, what can be the pathologies here? Same, carotid artery dissection, carotid artery aneurysm can also involve things here. And here there is another important anatomic consideration. Here is the cavernous sinus. As the carotid, internal carotid artery, common carotid artery, external carotid artery, internal carotid artery. Now in the internal carotid artery is entering the cavernous sinus along with the sympathetic chain. So in the cavernous sinus there are other cranial nerves, 3rd, 4th and 6th. So Horner syndrome along with 3rd, 4th, 6th cranial nerve palsy, that is the cavernous sinus thrombosis. So cavernous sinus thrombosis, Horner syndrome here. So from here to what are the different causes of Horner syndrome? Okay, and now when this oculosympathetic part is damaged, what is happening? Paralysis of the Muller's muscle. So this Muller muscle is paralyzed, so there is ptosis. Eyelid is coming down. But there is a beautiful thing about this ptosis. This Muller's muscle is paralyzed. Upper eyelid comes down. This Muller's muscle is paralyzed. The lower eyelid is pulled up. Because of paralysis, this lower eyelid is pulled up. So the palpebral fissure of the eye is narrowing down. This is the ptosis part. Lower eyelid is pulled up. So this is the palpebral fissure which is visible. So there is decrease in the palpebral fissure. That is why the relative enophthalmos, eyeball constrict nahi hua hai. Eyeball is not constricted or shrunken. It is this Muller's muscle involvement. Upper eyelid comes down, lower eyelid pull up, decreasing the palpebral fissure significantly, which do not occur due to paralysis of the levator palpebrae superioris, which is due to the 3rd nerve palsy. In that, lower eyelid doesn't come up. Here the palpebral fissure is narrowed down because the lower eyelid also comes up. This is also known as upside down ptosis. Upside down ptosis, which is causing relative enophthalmos. Now as we see here, also there will be damage to the pupillary fibers. So there will be constriction of the pupil, which you already discussed. I am explaining the why there will be paralysis, because again sympathetic damage, no pupillar dilatation, pupillary constriction on one side, that is meiosis. Anhydrosis and anhydrosis part you can see here through the 5th cranial nerve, external carotid artery के साथ pseudomotor and vasomotor fibers are going on. So anhydrosis will occur, any pathology at any level from the hypothalamus up to this level of the superior cervical ganglion. But once the pathology is beyond the post-ganglionic part, there will be no anhydrosis. No. Why no? The branch is below. We are talking of pathologies above the ganglion. So remember, Horner syndrome with anhydrosis, site of lesion preganglionic. Horner syndrome without anhidrosis, site of lesion postganglionic, because ganglionic fiber यहाँ खत्म हो गया, इसके बाद नहीं है, यहाँ पे हमको anhidrosis नहीं होगी. So this is how the pathology, pathoanatomy causes of Horner syndrome. Now, can we diagnose with some other aids? So it's the clinical diagnosis, but remember it is not so easy. It's not an easy diagnosis like a third nerve palsy. There is a ptosis, there is a overwhelming mydriasis, and there is and the eyeball is pushed down and out due to unopposed action of the lateral rectus and superior oblique. The things are not so honky-dory here. Horner syndrome is so mild that sometimes you can miss the myotic eye. One side mydria, one side normal pupil, one side a slight myotic pupil. You can miss sometimes. And this is what is known as anisocoria also. So you can miss this anisocoria. So to confirm Horner syndrome, if there is a suspicion is there, you will confirm it. I will confirm it by insulating one eye drop. I will apply or I will put in this eye drop, aproclonidine eye drop 0.5% in both the eyes. What is this aproclonidine? It releases the noradrenaline through the synapses. So this is a alpha agonist. This alpha agonist will release norepinephrine from the synaptic cleft in the sympathetic ganglion. What will happen is, if this is the Horner syndrome pupillary myotic eye, this is normal pupil, this side Horner syndrome. Because of the denervation, nerve supply कट गया ना, nerve supply कट गया है भाई, तो जो denervation हुआ है, एक फिजियोलॉजी में आप लोगों ने पढ़ा होगा, the concept of denervation, super sensitivity, or denervation hypersensitivity. So because of this denervation hypersensitivity, this pupil will dilate. Because these nerve endings are hungry. They are, because of denervation, they are hypersensitive to a slightest stimulus, alpha agonist stimulus. So this pupil will dilate. But this pupil will constrict. Because there is no denervation hypersensitivity here, and rather excessive release of noradrenaline will give a feedback so that no noradrenaline is secreted excessively. No noradrenaline is secreted excessively in this part of the synaptic cleft because there is no denervation hypersensitivity. So in this test, the Horner's pupil will dilate and the normal pupil may constrict, and this will confirm Horner syndrome. Aproclonidine eye drop test. After 1 hour, I will see this response. And now another eye drop test I will do. That is hydroxyamphetamine eye drop. 1% I will instill in both eyes. This hydroxyamphetamine eye drop test will tell me the site of lesion. Again it will throw the noradrenergic stimulation, and if after 1 hour both people dilate, especially the Horner people will dilate, then the site of lesion is preganglionic. If there is no dilatation, even after hydroxyamphetamine eye drop, no dilatation, inability of the myotic people to dilate, then the lesion is post-ganglionic. So this test will tell me the site of lesion, whether it is preganglionic or post-ganglionic. Coming to the treatment, nothing. Treatment of the cause. Identification of the clinical scenario like I have described, brainstem syndromes, hypothalamic syndromes, ब्राकियल प्लेक्सस इंजुरी होगा तो क्या होगा, मसल वेस्टिंग. सो एसोसिएटेड एरियाज के जो क्लिनिकल साइंस है, यू हैव टू आइडेंटिफाई देम, यू हैव टू डू दिस eyelid टेस्ट and try to treat the cause. This is in nutshell what is Horner syndrome.